I would like to be able to open the forum for any questions that people might have.
Wonderful, Dr. Rodriguez. Thank you so much. That was really very educational. Um, just as a reminder to the audience, you can type your questions in the chat box, and so I will read out those questions, um, and we'll try to address every question that you guys may have for Dr. Rodriguez. But I'm going to start off with some questions submitted by the audience in relation to your talk. I mean, that was really comprehensive. You literally hit it from front to back, top to bottom, in terms of the spectrum of choices of therapy, both pharmacologic and non-pharmacologic, that patients have nowadays. Whereas I kind of like it that you mentioned in the past that all we had in the past was levodopa, right? And then nowadays we just have so many choices. So as a specialist in your field, do you still go by the tenet of go levodopa first because it's the best and the most powerful drug versus maybe try some of these weaker medicines first? So what is your approach when you first diagnose Parkinson's in the early stages, untreated?
Great question. So the first thing that I do is I pull my prescription pad and I write there, you need to exercise. So that is the first treatment for people with Parkinson's disease. And I cannot stress enough the importance of exercises. I personally believe that some of the best data that we have for Parkinson's disease and trying to slow down Parkinson's is exercising regularly, 75 to 150 minutes every week, and then following a good diet, trying to lower sugar. So there is a lifestyle aspect that needs to be introduced, right? So we go over this with every patient, including meditation, mindfulness, and so on, as part of the treatment with Parkinson's, right? Then after that, for younger patients, and we're talking people in the 60, 65 years old, those are that's what I call my very young population. I probably will begin with maybe a low dose dopamine agonist just to try to improve some of the symptoms, because I make it clear to people that the main goal of therapy is, it's great if they look normal, right? But the main goal of therapy is not to make them look normal. The main goal of therapy is that we have to be strategic for them to maintain their ability to care for themselves, because they're going to live a long life with Parkinson's disease. So we have to come up with this strategy where we are using the lowest amount of the medications in a good combination. So in those patients younger than 60, 65, I will begin with a low dose dopamine agonist, bring it up slowly. Those that are in the 65 mark, then I will go ahead and begin with the lowest available dose of carbidopa, levodopa that will provide some benefit. And I will use levodopa as the main drug for them.
Yeah, and then there was much press in the beginning when Azilec was released many years ago, which is rasagiline, and that this it was claimed that it came very close to potentially having a neuroprotective effect in Parkinson's, or at the very least, a disease-modifying effect if given early. So when do you use rasagiline in your early Parkinson's patients?
So you know what, I actually offer rasagiline in the early stages. And the reason is this, when you look at the data, the rasagiline 1 milligram met that criteria, those 3 steps, right? So we have some data that shows that it can delay the use of levodopa, right? So I will go ahead and offer this to my patients, and I always used to say, so back in the day, sometimes it's hard to get these medicines just because of cost of the medicines and so on. But I always tell people, listen, if we can put our hands on this medicine, I think that it might be worth it to use it. So I go up to 1 milligram based on the clinical studies.
And then some studies also seem to suggest that the lower the dose of levodopa in the early stages, the better. And one study even suggested maybe keeping the dose of levodopa in the early stages to 400 milligrams or less, with the observation that perhaps many of these patients tend to develop, dyskinesias a little later if you keep the dose low. Do you abide by that, 400 milligram, maximum dose? Because when I was a fellow, not too long ago,
Hmm.
I remember that low dose levodopa was considered about 600 milligrams or less. And then when this study came out, that ceiling for what we label as low dose levodopa seems to have come down. But do you kind of adhere to that, or do you go by something else?
No, no, I do adhere to that. So I go up to 450 of levodopa, 1.5 tablets 3 times a day. And the reason is that, you very well know that some people have a tremor that is a little bit more difficult to treat, right? It's a little bit more resistant. So they might need a little bit more than other people. So up to 450. And then at that point, I say, let's hold it here. Let's see what we can do. And then we go back over that conversation about what is it that we really want from the therapy, and about the strategy to treat them.
Yeah, and then one of the burning questions that was submitted by the audience before the webinar was, what are your drugs of choice for patients with severe tremors in Parkinson's? How effective is levodopa, or do you choose something else, or do you combination therapy?
Yeah, so let me tell you, I try levodopa, and I go up to 2.5 tablets, right? So my high dose of levodopa is 2.5 tablets. At that point, I say this is a good dose, right? I can count with the fingers of one hand patients that take 3 tablets or more in the practice. Some people show up in my practice like that, but I think that past 250 of levodopa, I don't see a lot. And then there was a study that used a combination of levodopa plus pramipexole, and those patients experience about a 30 to 35% reduction in the tremors, and so that was beneficial. However, there's some people that it just doesn't matter what we do, how much medicine we give them, they just continue having tremors, right? And especially when it is in the dominant hand, it can be quite disabling, quite annoying. So those are patients that immediately when I see that happening, I explain to them that I don't think that adding a lot more other medicines is going to make much of a difference. And we begin to have the conversation about, surgical options for the treatment of Parkinson's and Parkinson's tremor.
Yeah, and I have to echo that. I think if there's one reason that a patient may earn an earlier ticket, for deep brain stimulation, it's tremor predominant, severe tremors that is resistant to even high doses of levodopa. So when you say 250 or 300, are you referring to 250 or 300 milligrams per dose, or is it the per day total?
Per dose.
Dose, that's what I thought. So
Yeah,
if you
so
go, let's say 3 times a day, so 250 is 750 milligrams. If it's 300,
there you
that's
go.
almost 900 milligrams, which is a pretty high dose.
Yes, that is correct.
I agree. And many of my patients with severe tremor predominant Parkinson's that have both, a rest tremor like this, when their hands are rested, and when they're doing things, their hands are kind of doing this as well. So it's a mixed tremor, both at rest and action or posture. Many of these patients just don't respond very well to levodopa at the maximum tolerated doses. So I kind of do the same thing that you do, which is, I add a dopamine agonist. And then what about amantadine or maybe anticholinergic drugs for tremor?
Wow, that is it's a great subject, right? So let me tell you, it's very interesting because I used to do a forum for people with Parkinson's disease. There was about 40 to 50,000 people connecting there.
Wow, that's huge.
Yes, it's huge. It was huge, and a lot of the times one of the issues was the use of benztropine or trihexyphenidyl,
Right.
for the treatment of tremors in people with Parkinson's. So let me, this is how I explain patients. I tend to use that mostly with younger patients. And once again, the line is drawn at the age of 65 years old in my case, because when I give the prescription, I'm looking at them in the face and telling them, I'm going to try this medicine, and there might be the possibility of having some memory problems, confusion, hallucinations, bladder retention. So the side effect list is higher, and it's a little bit more likely that it's going to happen, but it can help with the tremors at the same time. And typically what happens is some patients will have great improvement of the tremors, dystonia, stiffness, cramping. They love it.
For sure.
They go by it, right? And I use 2 to 4 milligrams between 2 and 3 times a day. Sometimes some patients I go to the 5 milligrams 2 or 3 times a day, but that's it. Past that point, we run into problems, right? So I will use it probably in the younger patient that have some tremors. I am afraid of using it in the people older than 65 because of the cognitive impairment, the possibility of falls, and then the issues with bladder retention. So they might see some benefit, but they will deal with the side effects.
Right, right. Do you have any success with using amantadine for tremors though, outside, without the anticholinergic drug? We know it has some anticholinergic properties, but
Yes.
how successful are you with amantadine in your tremor predominant Parkinson's patients?
So I have not been much successful. I tried it before years ago, and I took it out of my roster for that particular population. But if you find it useful, I'll definitely bring it back and try it again as an option.
Right. Okay. There's a long question here from one of the participants. I'm going to read it out loud to you. Um, my 70-year-old sister was diagnosed with Parkinson's 5 years ago, and is now in stage 5. Parkinson's with dystonia in 3 limbs, with sleep issues and hallucinations. We have no confidence in our doctors in rural California, where there are no specialists. She eats very well and is very well motivated. She's on many prescribed medications. What should we focus on with her, and in terms of medicine therapy? And this is a common scenario where patients are on polypharmacy. So do we just keep on throwing one drug after another at these patients till they hallucinate and get confused and
Listen,
blood pressure? What should we do for complex patients like this?
so the first thing that we need to do is clear the slate, right? Like
Yeah.
clean the kitchen. And I try to, people come with shopping bags of medicines. And the first thing I tell them, I'm going to give you an example. Just yesterday, I saw this wonderful veteran, and he's coming with memory problems. He has problem with drooling, memory problems. He's having hallucinations. He's having trouble walking. And when I look at his medicine, so he's taking anticholinergics to help with the drooling, but that is causing the memory problem and the hallucinations. He's on amantadine 4 times a day on top of it. He is 74, 75 years old. So he's already a little bit more advanced age. So the first thing that I tell them is, the first thing that we need to do is follow the theme that less might be better. So let's begin to remove some of these medicines that might be associated with side effects, because listen, the answer is not always going to be let's add one more medicines. This is what happened in people with Parkinson. Remember that Parkinson disease being a progressive brain disorder, some people might be able to tolerate a medicine today, but because their brain is slowly deteriorating because of the Parkinson's, 5 years down the road, they might be sensitive to the medicine. So the medicine that was well tolerated might not be well tolerated 5 years from now, which defies conventional wisdom. We believe that because we have been on it for 5 years, it's still a good medicine for my loved one, or my husband, or the person I watch for. So we start taking the medicines, and I typically leave them on carbidopa levodopa, right? Because I'm trying to improve the motor symptoms.
Sure.
I try to clear those medicines that are usually associated with more side effects. And then we have to wait to see how the patient responds to these changes. So, definitely for this person, the main thing I can tell them is we have seen this before many, many, many times. And you need to work with a person that has experience with Parkinson's disease, that might be able to take into account the condition, corroborate the diagnosis, and then try to clear some of the medications that might be associated with side effects, just to try to give her more benefit.
Yeah, and at what point would you send a patient for deep brain stimulation? Like, how many drugs should they be on, or how long should they have tried the drugs? What kind of side effects will make you kind of say, okay, it's time for a DBS? When do you pull the trigger?
Listen, I have that nailed down at this point. So I use this rule. I call it the 5-to-1, and I'm sure that you heard about this already. So when I have a person taking carbidopa, levodopa, and taking their medicines, and they going into 5 times per day. So if I have a person taking the medicine 4 times a day, and now they need to move on to the 5 times per day, I immediately have that conversation like, listen, we are at a point in your condition that we need to start thinking about one of the other therapies that fortunately we have them available. Back in the day, there was nothing we could do, but now we have something called deep brain stimulation, or for that matter, intestinal carbidopa, levodopa, or one of the other therapies that might be coming in the future. So when they are going to 4 times a day to 5 times a day, and they are still wearing off, and if they're having at least 2 hours of wearing off, or 1 hour where they're dyskinetic and having what we call troublesome dyskinesias, those are the criteria that I use to tell my patients this is it. Like this is the time. And listen, what I try to explain people is people with Parkinson's disease tend to live long life, right? We care for these patients 10, 15, sometimes 20. I just had somebody that has 26 years with Parkinson's disease showing up in my clinic, right? So I tell them, listen, you are a better candidate for the DBS surgery today than what you will be tomorrow. You are younger today. You might be in a better shape today. And we already tried medicines. And, as a movement disorder specialist, we have tried, by the point we have this conversation, trust me, we try to make the pertinent changes to try to avoid getting to that stage. So when we finally bring that conversation, it's because we really tried the multiple options, and we believe that that might be the best option for you.